examine the patient with hypertension in the primary care setting.
Stop, Rainford.
Yes?
What happened?
Yeah, just start over.
It didn't start taping
We
you?
didn't get the
Is
audio.
that? Oh, we didn't get
the
the
audio.
Okay.
I tell you, it's a superstar life. It's not like, that's my, not like them thing, you know.
No, that's all right.
It's all right. No, I want to fix the cushion, the sheet a little. It's not as neat as it was before.
Okay.
So there's a lot of like tear up something. Third world medicine.
The other day, somebody went up to America and they had the same long wait at Kings County that we have at KPH.
Of course.
Oh, I was on top of ours.
Ready now? Ready now, guys?
No, foot over, foot
Everything.
over. There's some of that. Alright.
But he look, hold on, but he look like him in the way too much. You don't think so?
Yeah, because
You will edit that out.
to go here.
In terms of where the cameraman is right now.
He can't be in the way. Look how far he is.
I'm telling you this.
Oh, there's a camera over that side. Okay. 3 cameras? Okay.
No, we weren't seeing him before. Or when we were there.
Your colleague was here most of the time.
We were in a blind spot.
Okay.
Yeah, that's it. But you know what I forget? There.
That's it now? All right.
So we're good now.
You good now? Yeah. Okay, ready to roll. Intro.
Good afternoon, Mr. Thomas. Thank you for coming. Thank you for helping us with this project. You told us that you have hypertension more than 20 years, and in fact, you had a stroke 20 odd years ago, left your left side a bit weak. Today, we're going to be, with your assistance, demonstrating how to examine the patient with hypertension. And in looking at the patient with hypertension, we're looking at 3 main things. We're looking to see if there are risk factors that could contribute to the high blood pressure. We're looking to see if there are any clues to secondary hypertension. That's a particular factor which is causing the hypertension, not the so-called essential hypertension. And then thirdly, we want to look to see if any of the target organs have been damaged by this hypertension. And this Mr. Thomas has had a stroke, so we know about that already. So looking at one of the commonest causes for hypertension or commonest risk factors is obesity. I don't think we could describe Mr. Thomas as being obese. His BMI is probably mid-20s, so he doesn't have that. And just looking at him, a couple of the things that we could look for in this inspection is that he doesn't have a swelling in his neck, suggesting a thyroid gland. He doesn't have any redistribution of his fat, Cushing syndrome. And also, looking over to the outcomes or target organ damage, we could look for edema. We could also look for anemia in case he has kidney disease, going on to anemia as a target organ output. Doesn't appear to have any of those. Now I want to look for target organ damage. And I want to focus on the cardiovascular system. And first of all, one would definitely be looking to examine his pulses and to do his blood pressure. Recommended with a right size cuff. Mr. Thomas here would definitely require a normal adult, not a large adult with this arm circumference. And the arm would be at the level of his heart, and one would measure the blood pressure in the standard way. We definitely want to have a look at his blood vessels to see if we detect any hardening, so-called atherosclerosis associated with hypertension and other risk factors. But hypertension is a big contributor. No particularly hardening at his radial artery, but let's have a feel of his carotid pulse on the right-hand side. And I'm feeling the carotid pulse here. Remember to examine one side alone each time. And the carotid pulse is quite strong here. There may be just a little reduction in the volume on the right side. But both carotid pulses are felt quite normally. And then one would want to look for peripheral artery disease by examining the dorsalis pedis pulse. And both sides quite strong. Posterior tibial pulses And on the face of it, this gentleman does not have peripheral vascular disease. There may be some deficit that could be better detected by more sophisticated techniques like ankle brachial index and so on. But this gentleman has good pulses to his feet, so no peripheral artery disease. One then wants to look, continuing with the cardiovascular system, we want to see where his apex beat is. But first, we examine the trachea, make sure it is central, so we know the mediastinum is not shifted. This trachea is central. I'm going to try and find the apex beat. First of all, make sure it's on the left-hand side. And yes, his apex beat is easily felt. It's on the left-hand side. It's out in the anterior axillary line, so it's displaced. And just to measure exactly where it is, the manubrosternal junction is 2, 3, 4, 5. It's in the 5th left intercostal space in the anterior axillary line. So clinically, this gentleman has left ventricular hypertrophy or left ventricular enlargement, which is one of the commonest target organ damage we see secondary to hypertension. Want to listen to his heart, particularly listening for added sounds in respect of hypertension. Third heart sound would indicate maybe some left ventricular dysfunction, and a fourth heart sound, some left ventricular stiffness. Just roll over to your left side just a little bit for me, please. Big breath in and out. Stop right there and come back and sit up for me, please. Big breath in and out. Please lie down. I want to look if there's any sign of heart failure, and I'd really love to have him up at 45 degrees. Maybe this table will not support us, but that will do. Please hold your head back, sir. And I want you to look closely. His neck veins are not distended, but particularly we are looking to see the jugular venous pressure, and there's no sign that the jugular venous pressure is elevated on either side. And just to finish examining to see if there are any features of heart failure, please sit forward, sir. We're going to listen to his lung bases for any sign of fluids. Breathe in and out for me. And again, loud, with your mouth open. Big breath. And his breath sounds are nice and vesicular, and there are no added sounds, in particular no crepitations suggesting fluid retention. The next target organ I want to look at is the brain. We know he's had a stroke, but I want to focus on the features. It's been 20 years, and we want to look at some of the features. Looking at his face, right-sided stroke, left-sided weakness, I think I can convince you that his nasolabial fold is flat on that side and nicely creased on that side. Look up towards the curtain for us, sir. And his eyebrows, his forehead is nicely furrowed. His forehead is nicely furrowed, as you would expect in an upper motor neuron 7th nerve lesion, that it's preserved on both sides. But just look here, flattened in the left lower face. Show us your teeth, sir. Good. And you can see that that fold is definitely more prominent than that one. Puff out your cheeks. And I hope I can convince you that he's resisting me more on that side than on that side. So we think he has an upper motor neuron 7th nerve palsy in keeping with his stroke. Now quickly to look at the rest of his motor system and draw your attention to the posture. Upper limb, you can see the left upper limb is held in flexion at the elbow, flexion of the fingers, right upper, and this is his position of rest. The right upper limb nicely laying by his right side. And in the lower limb, a little bit of external rotation at the hip. want to draw your attention also to what is obvious loss of bulk on the left side. And we would measure it properly, 20 centimeters above tibial tuberosity, the circumference. And I think I would guess that we are seeing about 3-4 centimeters difference in circumference. We're actually seeing some spontaneous muscle movement here, large groups of muscles, and we call that myokymia. And that, in fact, could be a part of his hypertonia, which is a result of this left upper motor neuron damage. So we see his posture. I want to just look at his tone. Don't help me, sir. Just want to move. And this tone is nice and normal. He's not resisting me at all on this right-hand side. I'm going to do the same thing over here, sir. And you mustn't resist me. I'm going to try and straighten it out. And he's definitely resisting me there. And as I come back, resisting me, and then he gives way, the so-called clasp knife rigidity at the elbow, some resistance at the wrist, and of course, almost fixed flexion of the fingers at the MP joint and the proximal interphalangeal joint. So definite hypertonia over there. Right lower limb. Don't help me, sir. I'm just going to move up and down. Then I'm going to use your leg like that. Little stiff on that side. But when compared to this side, no doubt about the difference. Held in full extension, markedly increased tone. Markedly increased tone. I could hardly bend it. Coming back, we're going to look for clonus. This is a normal side, normal tone. And on this side, just relax the knee for me, please, Mr. Thomas. Just relax. Try and relax. I'm not eliciting any clonus, but I suspect that our plantar response is going to be abnormal on the left. And here we go. We're going to touch his foot. He's rather sensitive, but notice that that big toe is not being extended. Let's go again. He's withdrawing, but the big toe is flexing. Let's compare to the left side. Just relax, please, first. So just relax. Okay, Mr. Thomas, just relax. We need to allow this hypertonia to go down. And here we go. And big difference. Unequivocal extension of that big toe. That's a left upgoing plantar in keeping with an upper motor neuron. So what we have here is postural changes in keeping with hypertonia, loss of bulk, not typical in upper motor neuron lesion, but after 20 years, so-called atrophy of disuse compared to the right side, increased tone, and finally, we're going to look at his reflexes. And that's a normal reflex on the right side there, compared to on the left side, much increased. All right? Look a marked difference between the brachioradialis reflex on the right compared to the left. And let's look at the lower limbs. Just relax, so don't put any strength in it. Normal flex here, a little brisk perhaps, but when compared to the other side, try and relax, Mr. Thomas, just relax, just relax. Look at that, unequivocally increased compared to this one. And the ankles, nice, normal ankle jerk on the right. Relax, please, Mr. Thomas. Getting a little tired? Just relax. Gonna bend this a little bit. It's quite hypertonic here. Sorry, just a little bit. Okay. All right. Just gonna bend the knee just a little bit. Okay, it's quite hypertonic. We're not able to demonstrate it as well because he's just not relaxing sufficiently. So unequivocal left upper motor neuron lesions in keeping with a stroke. Try and relax him. We're going to then turn our attention to the abdomen. Just want to expose you a little more, Mr. Thomas. Just expose you a little more. You still comfortable? Yes. Looking at his tummy, it's quite symmetrical, nothing obvious. His umbilicus is inverted. Just going to quickly scout around. Nothing. No pain, sir. Not tender in any way. Quickly feeling there. No obvious hepatomegaly. But our real reason for looking at the tummy is to feel for the kidneys. and trying to ballot a kidney on the right side. We're feeling for an enlarged kidney. The polycystic kidney could be a cause of hypertension. And just doing on the left-hand side. Just relax for us. If you're having any discomfort, let us know. And I'm not feeling any ballotable mass. And then I'm going to listen to the abdomen for any bruit suggesting that there are narrowed renal arteries. There are other causes of bruit in the abdomen, but in particular, if we heard a bruit, among our suspicions would be narrowed renal artery stenosis. Please sit up first, sir. We can listen over the back also. Right. And there are no bruits there. Finally, I'm going to ask him to sit up. Please sit up, sir. I'm going to ask you to turn around this way because I want to look into the back of your eyes, because the eyes is one place that you can see an actual blood vessel. It's the only place that you can see an actual blood vessel in the live, healthy patient without causing any discomfort. And it can confirm hardening of those arteries that we were looking for by looking for absent pulses and other changes that can take place in the back of the eye when the blood pressure has been out of control for a while or is out of control to a great extent at present. So I ask you to look straight at the wall over there. Don't look at me, don't look at the light, just focus on the wall. Begin out here, focus on the pupil. You see the red reflex, and as you go in, thankfully, he has no cataracts, so I can see the retina very well. I'm seeing the disc, which is nicely outlined. Keep looking at the wall, please, sir. And I'm looking for what we know as the different stages of hypertensive retinopathy. Please keep looking. So the examination of the fundus, you should have a protocol. I would suggest that you look at the disc first, then you look at the blood vessels, and then you look at the retina. And in this hypertension patient, if there's acute hypertension, you could see blurring of the disc margins. If the blood vessels, whether acute or chronic, you could see narrowing of the blood vessels, initially silver wiring, copper wiring, AV nipping or AV crossover problems. And then, if there's acute damage with severe acute hypertension, you could be seeing some retinal damage, in particular, soft exudates around the disc or even some hemorrhages closer to the disc. And he has none of those excepting for significant narrowing of his arteries compared to the caliber of the veins, which are in keeping with so-called grade 2 hypertensive retinopathy, nearly not pathognomonic of hypertension, but in keeping with hardening of his arteries. Please lie down again, sir. Right. So in this patient with hypertension chronic, we have looked, doesn't have the typical obesity, which is one of the commonest risk factors for hypertension. He has no clues to suggest that he has secondary hypertension, the list you can think of: Cushing's disease, thyroid disease, neurofibromatosis, kidney enlargement, or narrowing of arteries to the kidney. Looking at the target organs, he's definitely not in heart failure, but he has clinical left ventricular hypertrophy. The apex beat is in the 5th left intercostal space all the way out to the anterior axillary line with a central trachea. So we think he has clinical left ventricular hypertrophy, but he's not in heart failure and he has no arrhythmia. Neurological system, he's definitely suffered a stroke. It's been going 20 years now. Unfortunately, the rehab has not been good, and he's still weak on the left side with some of the features of an upper motor neuron lesion, hypertonia, hyperreflexia, upgoing plantar, and some atrophy of disuse. His kidneys, again, we would assess that biochemically, but clinically there is nothing. Is retina, just manifest. Second, grade 2 hypertensive retinopathy, nothing acute, and just in keeping with the atherosclerosis that high blood pressure induces. So just to summarize, we're looking for anything that is a risk factor for hypertension. We're looking for features that there has been target organ damage, in which case we have one here. There's been brain damage causing stroke on the left side, right side of the brain, left-sided weakness. And then we're looking for any clues that there may be an underlying cause for the hypertension, which we don't see any of it manifested here. We're going to stop there and see what you think. Right. I don't know how that went.
It went well. Why don't you just tell the gentleman thank you?
Come on. Yeah. Thank you very much, Mr. Thomas.
Anyway, Mr. Thomas, that was just round one. You're feeling cold? You're not, are you all right? You're all right.
I am hot, so you can't be cold.
So Ishmael,